So as far as the continuum of care in patients with metastatic colorectal cancer, your first-line chemotherapy will always have a major impact on your second-line decision. And I think as we are using more first-line anti-EGFR therapy in patients with RAS wild-type tumors, we start thinking about what is the optimal second-line treatment. In patients where we start with bevacizumab, there's also the question, do you start with anti-EGFR therapy? Do you continue with anti-EGFR therapy in the second line or not? This is a complicated process because there is a lot of different first-line treatments, not just with the targeted agents, but also what type of chemotherapy you start with. What if you start with FOLFOXIRI, for example, plus bevacizumab? So in a simple way, I would say, if I start with a bevacizumab-based chemotherapy regimen, I think it's fair to say, if you're starting with FOLFOX bevacizumab or FOLFIRI bevacizumab, the data is not very clear that you have to go to a second-line anti-EGFR therapy in patients with RAS wild-type tumor. The data is clear that those patients who receive anti-EGFR therapy in the second-line treatment will have a higher response rate, to the order of 35% objective response rate if they have a RAS wild-type tumor. So if I have a patient with high volume or high burden of disease who has progressed on first-line chemotherapy, do I continue bevacizumab in the second line, or do I use FOLFIRI plus panitumumab, or FOLFIRI plus cetuximab, or irinotecan plus an anti-EGFR agent? I think the answer is clear that I would go with an anti-EGFR agent in that setting because the patient is likely symptomatic, so we need to downstage the disease, or the patient has high burden of disease, so you have a risk of having organ failure if you have a quick progression. So I would go with downstaging and I would go with an anti-EGFR therapy. Continuing second-line treatment with bevacizumab-based therapy or any other anti-androgenic therapy after bevacizumab progression on the first-line treatment is really associated with an objective response rate of about only 10% or less. So you have a very big difference in what you expect in objective responses. So for that patient population, I think the answer is clear. For a patient population that has low volume disease that has progressed on first-line chemotherapy, I think it is not clear if one is better than the other, and I think both are options. If you do not want to deal with skin toxicities yet, you can leave your anti-EGFR therapy till later. We certainly know from the TML study, which is continuation of bevacizumab beyond progression, beyond first-line progression on bevacizumab, that there is an improvement in overall survival by continuing bevacizumab. We also know from the Velour clinical trial that there is benefit from aflibercept in the second-line treatment. And now we also know from the RAS clinical trial that also using ramucirumab in the second-line treatment after bevacizumab progression will improve overall survival. The improvement, however, we have to all be kind of aware, is not robust. It's really in the order of about 1.5 months, and the median survival is improved by about 1.5 months on those agents. And the hazard ratio has been somewhere between 0.8 and 0.85, which means that there is about 10 to 15% or about 15% prolongation in overall survival with anti-androgenic therapy continuation. So high volume disease, I think anti-EGFR therapy for RAS wild-type patients. Low volume disease, I think there's no winner at this point, either anti-EGFR therapy in the second line or continuation of anti-androgenics in the second line.